plaque and calculus, calculus, plaque, and these are important, especially the plaque and calculus from clinical point of view, in periodontology. When you clean the teeth periodontally, you have to consider these things, and the gingival clavicular fluid is important diagnostically. It is a fluid is producing into the gingival sulcus. Into the gingival sulcus, it is forming continuously. There are two main types of this fluid: transudate and an exudate. As I repeat now the lecture, of course. You can see here the gingiva with different components, and the attachment level is normally in healthy young situation is under enamel region near the neck area, near the cervicular area of tooth. You can see the attachment apparatus here, or the attachment junctional attachment epithelium, and we have the gingival sulcus, which is normally in healthy situation only virtual gap, because this gap is closed completely, but there is a very virtual space between the inner membrane of the or the inner epithelial lining of the free gingiva. This is the free gingiva above the bony level. Please a little bit not so noisy, please. Okay. So we have the gingival free gingival area, and this free gingival area inner surface is where the gingival sulcus and the gingival clavicular or gingival sulcular fluid is producing continuously. And I mentioned you that this production is different in different areas. It is produced extensively between teeth, and especially the molar area, the so-called caul area, between the two papillae, the inner papillae and the outer papillae. This sensitive caul area is the area where the most of the gingival fluid is produced and is found. Here it is producing extensively in this area. And you can see here the anatomical basis of this topic, the structure of the marginal gingiva, the different epithelials, and the underlying tissue, which is a firm connective tissue, and we have the attached gingiva, which is firmly attached to the bone surface, to the alveolar process bone surface, to the outer surface of the bone. And sometimes, and most of the authors say it is not a transudate, but it is an exudate. So even the gingiva is clinically healthy, minimal histological inflammation is found usually, So you cannot clean perfectly your gingiva. You have a lot of bacteria, more than 300, 500 bacterial species you may found inside the oral cavity, and unfortunately the minimal inflammation is almost normal. So there is no person with absolutely histologically healthy gingiva, because it is almost impossible, to maintain so perfect oral hygiene. And this is the reason why they say that this gingival fluid is actually not a transudate, but it is an exudate. And it doesn't mean, of course, that most of the people need periodontal intervention. Of course, we have some periodontitis, mild periodontitis. You need scaling, and in some of the cases, we need serious radical intervention, even surgical periodontal intervention with deep pockets. The significance of this gingival sulcus is the pocket formation, pocket formation, because the gingival sulcus is when it is less than clinically measurement is possible, of course, with periodontal probe. When it is less than 3 millimeters, it is healthy, it is normal. So there is no need to special periodontal intervention. But when you have deep pockets more than 4 millimeters, you have to recall the patient and continuously treat the patient, the periodontal condition after this gap is closed and after the situation is normalized. When it is every little area with active inflammation and with deep pocket formation should be treated until it is solved. Okay, until it is diminished or the inflammation is treated. Should be any inflammation or area deep pockets should be treated periodontally. Of course, in my cases, general dentists can do this treatment, but when you have very deep pockets in multi-rooted teeth or along multi-rooted teeth, special periodontal intervention is needed. Periodontologists, we need specialists, we need to treat sometimes surgically, as I mentioned you, because when you have multi-rooted teeth, the anatomy, the root anatomy is very complex. The patient cannot treat, and the general dentist cannot treat with traditional conservative way. For example, scaling. The brushing is effective until 3 millimeters of pocket depth. The traditional scaling or the traditional dental, so normal dentist work is effective when it is less, the pocket is less than 6 millimeters. But when you have pocket depth more than 6 millimeters, you have to refer the patient to periodontologist to treat and to consider the surgical intervention, sometimes with bone augmentation, of course. And so this is the gingival sulcus. I have mentioned you this space, and is the gingival sulcus, and the depth is important histological, and the clinical measurement is important here. I mentioned you the clinically it is less than 3 millimeters. And when you have inflammation, the gingival clavicular fluid production is accelerated, is increased significantly. So the inflammation, but other stress factors. For example, when the brushing habit is bad, even the bad brushing is increasing the production of the clavicular fluid. You can see here the transudate theory here. So we have here the blood vessels, of course, and through the walls of the blood vessels, the blood plasma will migrate into the extracellular place and through the membrane, through the epithelial lining into the sulcus. But this sulcus fluid production is appearing in the sulcus when the lymphatic vessel capacity to take away the fluid from the extracellular space is less than the production of the fluid. So the production of the fluid is higher than the takeaway of the material from the lymphatic vessels. And as you know, in inflammation, the vessels are dilated, the blood vessels are dilated, and more material as sulcus fluid material will migrate into the extracellular space and into the sulcus through the epithelial lining. So it will be an exudate. And you can see here the function. I have, it is seen in the lecture. So cleansing function, we have a protein content, antimicrobial and antibody activity, cellular and IgG and IgM activity we have in the sulcus. So it is a protective fluid, in normal healthy situation, it will defend your neck area, you know, your even your teeth, you know, because neck caries is seen when you have plaque formation. Here, the plaque can cause caries problem and can cause the plaque, different plaques of course, but the bacterial plaque can cause cardiological and periodontal problems. It depends on the clinical situation. Sometimes the patient is sensitive to periodontal lesions. For example, I mentioned you that the diabetic persons are very sensitive to periodontitis. And you can see here the most important components. We have cellular component, mainly neutrophils, so polymorphonuclear cells. We have in 90% of the cases, 91% of the cases, we have neutrophils inside, but mononuclear cells in the rest, you know, so 10%, around 9-10% we have mononuclear cells, lymphocytes mainly, and phagocytes inside, mononuclear phagocytes we have. And we have organic materials, proteins. The protein content is increased in inflammation because it will become an exudate. And the bacterial content, PS, we have lipopolysaccharide, we have inside the sulcus and other byproducts. And the inorganic materials, natrium or sodium or calcium content. Calcium is an indicator, and calcium could be an indicator of periodontal lesion, you know, because in cell destruction, the calcium, the potassium, extracellular potassium concentration is increased in cell destruction. So it could be a diagnostic indicator in periodontitis, you know, because when you test the patient for periodontitis, you may use this fluid to estimate the risk of the periodontitis, because you have to select the risky patients, okay? Because maybe one of you has some risk for periodontitis, but the other may have much more risk for periodontitis. And when you have, you know, bad habits, for example, smoking, it may increase your risk. So, of course, it is a screening. It could be a screening examination, and the goal of the screening examination is to identify two risky patients. You know, because not the others, the healthy, the majority, but the risky patients are very important to identify and follow. In the following treatment, you have to record only the risky patients, not the majority, of course. And these diagnostic laboratory tests may be used, you know, to identify sometimes the bacterial content is important. You know, what type of bacterial species are growing inside the oral cavity, because there are periodontal pathogen bacteria, or there are patients with lack of defensive mechanisms. These are risky patients with bad bacterial content, with bad flora, or not strong defensive mechanisms. So when you investigate or evaluate the fluid, you may answer which patient is risky or which patient is healthy, and there is no need strict follow-up for a strict follow-up. And we have the inflammational material. Page 8, for example, we have here prostaglandin E2, which is a very sensitive material to estimate the bone destruction. Some interleukins, and the prostaglandin E is a very important marker for bone destruction. And you can measure this marker content in the sulcus, and you will see that in periodontitis, especially in the young person, juvenile periodontitis, the level is much more higher than in healthy situation. And we have some molecules, interleukin 1, beta, alpha, and 6, 8, which are accumulating when you have periodontitis, so inflammation and bone destruction. Because the inflammation side effect is the bone destruction. So not the gingival inflammation with bleeding is important here, but as you know, the surrounding bone may strengthen the whole tooth. And when you have inflammation, the bone is dissolved. And the bone desorption is increased or accelerated when you have this interleukin content into the sulcus. So the sulcus content may show you whether the bone is endangered for destruction or not. So interleukin content and tumor necrosis factor could be an important indicator or marker, and as you can see here, so in etiologic investigation of periodontitis, these could be very important markers. Okay, and there are some enzymes, you know, in for example, bone changes or connective tissue destruction, and for example, the beta glucuronidase is in the gingival clavicular fluid, GCF, is a good marker to estimate the attachment loss. AL means attachment loss, or you know, in periodontitis, you can diagnose the periodontitis when you have attachment loss, means migration of the epithelial attachment apically. So gingival retraction and bone destruction, bone loss, attachment loss, this is similar. So in attachment loss, you can see that this enzyme content is increased, you know, higher in concentration. This enzyme is higher in concentration and in activity of the disease, because periodontitis is a chronic and inflammation is a chronic disorder, chronic disease. So sometimes the activity is, you can see the activity is increased, but sometimes you cannot see any activity, but the disease is there, or the process is there, but there is no significant disease activity. But of course, you have to concentrate the treatment when the disease activity is high, okay? Because when the disease is inactive, there is no need for effective and immediate treatment. But sometimes after clinical examination, it is not clear whether the disease is there, but you don't know whether the disease is active or not active. For example, when you take an X-ray picture, you can see picture X-ray, you know, you can see that there is some changes, bone loss, and so on, but you don't know whether it is active or it is just happening in the past, okay? But these evaluations or laboratory tests may help you to tell whether the disease is active or not. So we have other enzymes as well, reflecting the bone and tissue destruction. For example, alkaline phosphatase is a good indicator of bone changes. And we have bacterial content changes, bacterial tests from the sulcus fluid as well. I mentioned you that not only the host metabolism is changed and the defensive capacity of the host, but the bacterial content could be wrong, the flora could be wrong, and this could lead to periodontitis. So you have to screen the patient and the periodontal gingival fluid for this periodontopathogene bacteria. These bacterial species are very dangerous for the periodontium. I mentioned you have a lot of bacteria, but these more than 300 bacterial species in the oral cavity, but most of them are absolutely not harmful. So it is not dangerous. Just normal bacterial content we have, but we have these Porphyromonas, gingivalis, Actinobacillus, Actinomycin and Clevotella intermediate species could be dangerous, and we have chair site. So we have dental tests. You can take these dental tests in the surgery, and you can estimate again, as I mentioned you, the patient risk for periodontitis. So different tests could be used to estimate the bacterial level and whether the bacterial flora is dangerous or not dangerous, normal bacterial flora. And you can collect the GCF, the fluid, because the amount of production is different in normal situation than in unhealthy situation. So the measurement is important. For example, the saliva measurement. The saliva is a similar fluid, different but similar fluid than the gingival clavicular fluid or tear fluid measurements. You have to take to estimate the production, okay? Because the production will assign you that there is enough fluid production, because this fluid will protect when the production is very low or when the production is very high. It may mean pathological situation, okay? So changes in production is important. We have these methods. These are important methods. Absorbent paper strips, for example. This is the most important and most frequently used. Little paper strips inserted into the sulcus, and these paper strips become wet, and you may use different methods to estimate the production of the liquid, of the fluid. So we have intra or extra sulcular methods with paper strips, absorbent paper strips, to measure the fluid production. When it is too high or when it is too low, it is pathology. It could be pathology. And you can use cords like before impression. Before impression, that retraction cord type material. The twisted threads or retraction type cord type materials could be placed into the sulcus, and first, before you measure, before you insert it into the sulcus, you have to measure the weight of the material of the cord, and after insertion, of course, you remove the cord and measure it again. And the difference will be the coming from the big difference coming from the sulcus fluid. And pipettes, micropipettes could be used, but it is traumatic, it is said. But little, very little pipettes could be used, and it is difficult to take measurement, but it is a very good and clavicular washing. Similarly, micropipettes used with fluid content to wash away the fluid, the sulcular fluid, and you have to collect the material again, and of course it is diluted. So this after washing this fluid, it is diluted, but you can evaluate the content of the mineral content and glucose content, organic content. So you can do laboratory tests with that solution. And I mentioned you, this is the most frequent, the paper points, absorbent paper points can be inserted into the orifice of the sulcus or near the sulcus or into the surface. So superficial insertion is possible or deep insertion is possible into the sulcus. So when you insert too deeply, the problem is that you will generate extra production of the fluid. So it could be a false positive result, okay? False positive result because you as the examiner will increase the production, will increase the with mechanical stress, So extraclavicular method, intraclavicular, superficial, and deep methods would be used to measure the like these paper points inserted into the sulcus, and after removal you can see the what extent the paper point is wet by the fluid, and you can measure, or even with a special instrument, you can measure with this instrument the electrical current change of the material, because when the paper points is infiltrated with a lot of fluid, the electrical current measurement is higher in this instrument. So this instrument could be used to evaluate the circular production with measurement, with paper point measurements, because simply the current transfer is changed. And you can see here the situations where the gingival clavicular fluid is changed. There is a diurnal changes of the production, and we have the maximal production is between 6 and p.m. a.m. 6 and p.m. 10. So this daytime period is the when it is produced mostly, and but we have normal situations. For example, in pregnancy, the production is increased significantly. So in women, it is connected to the hormonal changes, and when we have contraceptive anti-contraceptive tablets, the change of the clavicular fluid is obvious, and so these are very important clinical situations. And the other clinically important aspect is the drug excretion of the drugs, okay, into the sulcus, because when you would like to treat the periodontal conditions with drugs, with antibiotics, for example, you should know whether the drug is excreted into the saliva, for example, or into the sulcus. Because when the drug is not excreted into the sulcus, so that is not any way for the work of the drug at the site of inflammation. So we need drug with high excretion into the sulcus. So there are some antibiotics which is measured. In these cases, you will know that the excretion is very high. For example, the tetracycline excretion into the sulcus is high, and metronidazole. So we use, as you know, metronidazole is regularly freon. The other name, I don't know in your country what is the name of this metronidazole drug. The active agent is metronidazole, but in Hungary it is is named as Cleon.
bed
It is used regularly. Metronidazole used regularly, even in ulcerative gingivitis, you know. And as you can see, this drug is excreted into the sulcus. In diabetes, as I mentioned you, and in mechanical stimulation and in smoking, the clavicular fluid production is changed. And we continue with the dental plaque. This dental plaque is produced continuously on the surface of our teeth. We have different dental plaques, and usually dental plaques are pathologic because this may cause caries or periodontitis. It depends on the plaque location and the type of the plaque, you know, because you have surface type of plaque, or we have fissure plaque, or we have subgingival plaque. The subgingival plaques or bacterial deposition may cause periodontitis, and interproximal and fissure plaques may cause caries. So caries and periodontitis, these are the most popular dental disorders. And these plaques are whitish and sticky deposits on the tooth surface, and you can brush away the plaque. It is important. You know, when you brush regularly and you can brush away the plaque, but below the plaque you have the pellicle. Okay, the pellicle. You cannot brush the pellicle away, but you can brush the plaque, and this is the meaning. This is the goal of the dental hygiene and the brushing, to remove the continuously accumulating plaque from the surface, from the tooth surface. And there are areas where the plaque accumulation is higher, for example, lingual, the sides of the anterior, lower anteriors, and the upper posteriors, the buccal sides or vestibular areas of the upper posteriors. And you can use agents, disclosing agents, to color the plaque, and you will see where the plaque accumulation is very fast and very effective, and the bacterial content is the dangerous here, because we have macromolecular content of the plaque and the bacterial content, and the bacterial content is dangerous. And you cannot remove the plaque with rinsing, with simple rinsing or chewing, because they say sometimes that chewing with sticky or with fibrous content, high fibrous content food may remove the plaque, but it is not true. There are two ways to remove the plaque: the brushing or the personal hygiene, dental hygiene methods, and the dental intervention. So professional and personal dental hygienic methods, brushing, these are the contents of the plaque, mainly bacterial, and we have microbial, intermicrobial matrix here, organic and unorganic macromolecules, mainly polysaccharides and glycoproteins, lipids inside the plaque. These are the most important parts, content of the plaque. And the types of the plaque, periodontally important that we have subgingival and subgingival. So below the gingival level and above the gingival level, and the removal is different. Formation of the dental plaque, of course, first we have pellicle on the tooth surface, pellicle, and to this pellicle and even to the native normal tooth surface, the enamel surface, the bacteria may adhere to the pellicle surface. You know, the pellicle in the pellicle we have large negative charged macromolecules, and the bacterial wall is usually positively charged, so there is an adhesion between the bacterial wall and the
glycoprotein?
yes, glycoprotein content. This is the glycoprotein is the pellicle, yes, of course. And after this adhesion, bacteria may grow and colonize on the surface of the tooth, and the plaque is growing and maturating, you know, because only well thick and well matured plaque could be dangerous for the periodontal tissues. So when the plaque is not matured and well thick, this will not be dangerous. You know, it means after 2 days, when you don't brush, after 2 days, enough thickness from the plaque is formed to cause some periodontal and gingival irritation. So the time factor is very important here. So when you clean your teeth regularly in every 2 days and perfectly, you know, your gingival and periodontal health will be maintained. So will be okay periodontally. But of course, your personal oral hygiene couldn't be so perfect. And the other reason that cardiologically you need more brushing because you know the acid formation, acid is level is lower in you know briefly. Not we need some days for the mature periodontal plaque, but only some hours for acidic level. And the adhesion in the plaque, you know, bacteria can connect to the pellicle level, bacteria can connect to the native tooth surface, and there could be interbacterial adhesion as well. And the bacteria can connect into the macromolecular components of the plaque, you know. So these are the possibilities of the bacteria for adhesion, you know, because the more bacteria should be adhered to the surface, and these are the 4 ways for the bacteria, so the bacteria can choose how to adhere to the surface, to the plaque surface and to the tooth surface. So the growing is in the plaque, and you can see here different bacterial species. And in early phase, you know, in periodontitis, in early plaque formation, the gram-positive foci are the most frequent bacteria, but later gram-negative dangerous bacteria may appear. So in some days, gram-negative bacteria can grow in the depths of the plaque because the plaque is thickening, so growing and thickening, and in the depths of the plaque, you know, the gram-negative species are the predominant species in the depth, and of course in the depths. And of course these are the dangerous. So the periodontal pathogens are gram-negative species. And you know, after classification, the plaque, as I mentioned, you soft. But after classification, calcium and phosphate ions are depositing into the plaque, and you know, classification can cause that the dental plaque may become into dental calculus, you know, dental calculus formation, and the dental plaque can be removed with brushing, but the dental calculus can be. So when you have dental calculus, you have to go to the dentist to remove, because personally you cannot remove, and this is, but not the dental calculus is dangerous for the periodontium, but the problem is that the dental calculus surface is very rough and the plaque accumulation is very high, you know, and that is the reason why the dental calculus is dangerous. So it is not so not the calculus itself, but it is always covered by, you cannot clean the calculus.
Better attachment.
So better the attachments and better the plug blowing, you know, and it is not clean material, you know, not clean, yeah, like your tooth surface. And so the main crystal forms in the calculus, you know, hydroxyapatite, dislocide, octocalcium phosphate, and blueshine. You know, the hydroxyapatite is the most matured and the best form of calcification, you know, but first less organized and less crystallized forms of the crystals are producing blueshite, for example, than the well matured hydroxyapatite, and you know, the supragingival calculus are less solid or firm, softer supra. So subgingival is very difficult to remove, and you need special tools, equipments to remove, and periodontal equipment subgingival, because subgingival calculus is forming from which is the source of the production of the subgingival calculus. No. Serum. Source of the subgingival saliva. Yes. Saliva. Okay. So this is why it is softer. It is harder. And the adhesion is different. Super and subgingival. Okay. Thanks and goodbye.